and won't be able to speak to the Re-Mobilization Plan just yet. So if we can just come to you, Tim, and for your annual report, which for which there was a link provided, I think.
Thank you, Paul. Yes, as members will know, the Director of Public Health, part of the role of the Director of Public Health is to produce an annual report, and this report is my second one as Director of Public Health for NHS Highland. The link is provided in the agenda. It takes quite an effort to produce the report. There's lots of hard work from lots of other people has gone into doing the report. Given the pressures of COVID within the public health team, I suppose the detail and the amount of work we've been able to put in has not been quite as much as before COVID. One of the specific features, just to mention on the report at the moment, with just because of some delays in getting all permissions sorted out for use of pictures and things like that within the report, there are certain elements that are still marked as draft, but it should only take a few days for the report to be published in its full format. The report this year takes a specific subject, as most reports do. Last year we looked at more response to COVID. This year, return to a theme that's been around within the annual reports for NHS Highland for a few years, and that's mental health. The focus is on both elements of mental health and of suicide. So I have a presentation I shall run through swiftly, and along with comments, and then happy to take questions. I would comment that the report is for noting. There'll be a lot of work which would be done outside the scope of this meeting and looking at implementation. So we're not asking for approval, but asking to note the report. So I hope members can see the presentation.
Yes.
I've really gone through the background already. It is a little bit eclectic, and perhaps a bit more eclectic than normal. There are elements of the report which, given more time, we could probably have fitted together better, but the chapters to a large extent stand on their own, looking at suicide and mental health. If we look at suicide, the numbers are concerning in the fact that there are a lot of deaths from suicide within NHS Highland. All deaths from suicide are their own tragedy and affect a very large number of people. And also, while with the eye of faith you might be able to see some trend, there certainly isn't a pronounced downward trend at all in numbers of suicides. More men take their own lives than women, but the trends are fairly much the same. And it's worth noting that NHS Highland rates of suicide are higher than those for Scotland as a whole. Argyll and Bute is fairly similar to Scotland, and the Highland Council area considerably higher. I talked about the pattern by sex and also by age. Is important to note, particularly when it comes to young men. And when we think about years of life lost from many conditions, the years of life lost for young men from suicide are really great. And you can see towards the left-hand side of the slide that the rate for young men in NHS Highland is very considerably higher than the rate for young men across Scotland as a whole. As for almost all conditions, deprivation is linked with suicide, both locally and nationally. Moving on from suicide, there is also a chapter in the report around self-harm. Again, the links are complex. Both suicide and self-harm are areas that need a lot of attention and a lot of work devoted to them. Rates of self-harm, again, are not going down. If anything, they're going up. But the rates for men and women are reversed in that the female rate is a lot higher than the male rate. Again, admissions from self-harm are concerning in this stage, particularly for young women. Moving on to COVID, one of the chapters considers the particular impact of COVID and mental health. There are some positive impacts from COVID around spending more time at home, but the negative with family, enjoying a better work-life balance. But overall, there are a very large number of negative impacts. Included within those are health inequalities, with many people who are already more marginalised suffering from worse mental health than before the COVID pandemic. This slide simply demonstrates changes relating to people on low incomes. So COVID impact affects really the whole community. This slide considers younger people, particularly education and contact with peers is has been a real impact on mental health. Again, there are positives and there are negatives, but the concerns are that we'll see much more longer term effects over the next 10 years or so from the effects of COVID. We've talked previously when we looked at social mitigation about income and loss of employment and things like that, but there are also significant effects on young people. The COVID effects on mental health and mental well-being will be particularly important for staff, and this just runs through a few issues that have affected staff who are in contact with COVID, and there's more information set out within the report. So as we hopefully come more towards the end of the pandemic, at least the beginning of the end perhaps, we do need to be particularly conscious of the connection between poor mental health and the pandemic. Moving on to talk about perhaps something a little bit more positive when it comes to suicide and mental health. There is a lot of activity both from the board, from the other parts of the statutory sector, and also considerable activity in the voluntary sector dealing with improving mental health and reducing suicide risk, which get elucidated in more detail within the report, both in terms of national strategies and also local strategies. There are particular programmes aimed at specific mental health issues, but also around improving overall mental health and well-being. Focusing back again on suicide, because the impact of suicide is so huge around communities and families, it's important to have special work there, both to reduce suicide and also to help people cope with the consequences. And so there are various resources for bereavement and support, which are again set out within the report. Finally, as all public health reports do, this one contains a range of range of recommendations, both around further work and interventions. There is considerable further work already being done, working with some colleagues from both within and outside the board, looking at trends and risk factors, and also looking to strengthen interventions. That finishes the presentation, and I'm very happy to take any questions.
Thank you, Tim. That's a very interesting presentation and a very interesting report indeed. Graham Hardy.
Thanks, Chair. Thanks for that, Tim. It's great to see a report coming to the board about mental health. And I'd just like to state that Mind are having a mental health talking day on February the 3rd, where people are encouraged to talk about mental health during the day, just to raise that point. And I'm glad to see that these issues are being taken seriously. And thanks for your report. Thank you.
Yeah, Alex.
Yeah, thanks, Boyd. Yeah, thanks, Tim. That's a very interesting report and a good presentation. Some of the things that have been pushed over the last few years in terms of health from a rural point of view is the farming community, particularly some of the younger farmers. Is that part and parcel of what you've looked at, or is that an area that hasn't yet been explored and broken down in that way? I'm particularly looked at the fact that Easter Ross shot up in terms of their numbers, 5 years ago versus this last 5 years. Thinking about the fact that there is a farming community, etc. in there. Thanks.
Yeah, thanks, Alex. I think in terms of individual localities within either of the council areas, it can be difficult to look at changes because the numbers will and the rates will vary. However, in terms of the farming community, it's well known that there is a very considerable risk for poor mental health, and particularly for suicide in the farming community, which comes from a range of different reasons, with things like income instability, the level of work, and also in particular access to means of suicide, and there's a whole lot of work being done and potential interventions available. So many people within public health are considering what more can be done. There is work that has been done with the farming community, but it's certainly high on the list for further work that does need to be done. And I think also many farmers are quite isolated, and there are a whole lot of risk factors that make the farming community one of the highest risks of any group anywhere in the country. So yes, that's certainly a very important point, and something that we're looking to do more work on.
Hey, Susan.
Thank you, Chair, and thank you, Tim. Very interesting report, and pleased to see it. My question is about babies born during the pandemic and the possible detriment to them, maybe longer term. We're talking about to their socialisation, maybe their language development, maybe detriments their mothers have suffered by being extra isolation. What can we do to make sure that they don't really fall behind in those very early years, which are so crucial?
Yeah, I think that's it's a real potential risk. There are issues around impact of COVID and the direct effects of COVID, which have been seen with other pandemics in the past on children's development. But perhaps one of the other most important areas of children's development is that many toddlers haven't had contact with other children because they haven't been able to be out and haven't been able to have that social social contact. I haven't got an answer to say what we need to do. I think it's there will be a whole range of things, including recognising that in terms of preschool and school provision, so that the needs are actually taken into account as the young children start meeting more and engaging and taking into account what's happened to them. And I think there will be people with particular special needs who'll need treatment, but I think overall it's probably more around childcare providers, around schools knowing more. So I think it's a very good question, one which I'm really not in a position to answer, but it's something that we will. I'll certainly take that away and discuss that with colleagues, and it's one of the more important of the very, very many legacies that we'll end up with from COVID.
Jerry.
Thank you, Boyd. Thank you, Tim, for an excellent report. Looking at page 33 of the actual report, where you draw a number of conclusions as it relates to mental health together. What I was thinking about is how are we actually going to pull that work together, given that NHS, the Highland area is already above average in terms of suicide with Tayside. I think you're indicating we need to do further work to understand the real causes of that. And we've got the pandemic, which will probably push that suicide rate up. And we've got I was about to say that the forthcoming energy crisis, but I think it's probably already here, and we've got the highest rates of fuel poverty in Scotland. There seems to be a lot of drivers coming along, which actually could make our suicide rate even worse. And it's how are we prioritising that work, but probably more importantly, how are we tying the outcome and the understanding that we have of those drivers into our emerging mental health strategy, which we were speaking about at the Health and Care Committee a week or so ago.
Yeah, I think in terms of the overall work on what the effect of the COVID and the interrelationship with changes in society is having on people's health, I think the main way that we are looking to address that is through the work on social mitigation, which has already been to the board. For the wider mental health picture, the community planning partnerships are particularly interested in mental health, and I think as we develop the approach there and their approach to mental health will probably be the most important way of looking at how things work on the ground. And I think that there is more that will need to be done to link in the clinical mental health work, both at primary care and secondary care, to more community-based initiatives, and also to looking further at suicide prevention, because of course quite a large proportion of people who do take their own lives don't have contact with any mental health services, and it's I think suicide is something where the ways to look at prevention are really huge. It's a wide thing, looking at whether it's people's income at one extent, or long-term conditions, or particularly serious and enduring mental illness at the other. The absolute numbers are not huge. The impact of the single cases of people taking their own lives are huge, and are massive. But also, what's huge is looking at what we can do. So again, there isn't an easy answer. But social mitigation, community planning, partnerships, and I think making sure that we link in is the way to go.
Graham.
Tim, you mentioned that the Argyll rates are more in line with the national figures, if I'm picking you up correctly. And has there ever been any comparative, I suppose, more of a qualitative study between why these differences might exist between the two distinct areas within the health board?
I'm not aware of any specific work. I think that people have speculated around some of the issues around in the Highland Council area, and it might, and some of it may link with what Alex was saying around particular, say, farming communities. People have associated it with generations of economic deprivation, but I think it's still a bit of a mystery. Perhaps mystery might not be the right word, but a bit something that we still need to find an answer to, as to why the rates in the Highland Council area are so high. And I've spoken to several people about this who've been here for decades, unlike me, for only a couple of years, and are still uncertain about it. So I think one of the things that I hope the report will do is to actually prompt for a bit more further debate and put things a bit more in the public domain, because there's one thing that I think isn't helpful, and that's keeping the issue of suicide quiet. So hopefully we'll come up with more answers. I don't think there'll be one simple answer. I think it'll be a whole range of different different factors relating to demography, the economy, and a whole range of different factors. But it's certainly a very, very interesting question.
Louise.
Thank you, and it is obviously an interesting, very concerning report. But I suppose one thing we've also got to consider is there will be a significant number of the people that complete suicide that we've had no contact with as a board. That in itself is a concern, because that makes the harder to reach group. So I think there's two things we've got to do. One is looking at the people that were already open to our services. Could we have done something differently? What else could we be offering those people? But also we've got to try and explore what else more assertively can we do for the population in general. And certainly things like we're looking at putting in primary care workers, mental health workers to support in that early stage. And if we can capture as many people as possible who are feeling depressed, anxious, concerned, whatever, at that early possible point, we may be able to intervene at a point where at the moment we don't, or we can't. So I think there's two elements. There's the people that we see already and what we can learn from that, and there's the people that we're not yet seeing.
Tim, do you want to respond to?
No, I entirely agree with Louise, and I think that, but part of that, one connection with that is making sure that we know what has happened, and that's behind one of the recommendations around a suicide audit, because it's important to be clear around what connections people have, who've been in contact with services, who haven't, what are the type of things that that we can look at changing, not particularly in an individual case, although sometimes there may be lessons to be learned, but it's more around what are the themes that are emerging, and what are the major types of policy or practice that could be changed that could actually make a difference. And it may be that we focus on the general population, or it may be particular groups of people who are at higher risk, whether the farming community, whether people who've been in the looked after system. There are things that we can do, but if we don't have the information or the desire to investigate, then I think we're missing something.
Did you want to come back, Louise?
Yeah, absolutely. Just to very much support what Tim was saying, and also about how we explore all possible avenues for support that aren't necessarily about them being from NHS Highland or from Highland Council. What are those community resources, those community protections that we can put in place, or support to be in place through third sector, or just generally through community support groups and the different phone lines, etc. So it's using all of that and bringing it together, because there isn't one, as Tim says, there isn't one size fits all for everybody, but there's certainly more that we can do.
Yeah, I think probably when Louise and Tim have probably said most of it, but I think I would just want to re-emphasise the kind of being able to speak about this. And I think in any of the studies that have been done, in any of the reports that have come out, they have absolutely described the need for the stigma to drop and people to feel able to say, I'm not coping, that it's not a feeling. Of course, that's easy to say. That's much more difficult to do when you're in that space where you feel quite often embarrassed about not coping, etc. So that's where I think the real societal kind of response and support is really, really important. And I think the other bit for us at a community level is, you know, the devastation across families and friends and that wider impact and what that does to them and their mental health, and having to live with quite often something that they don't fully understand. And just as Tim's highlighted, the kind of profiles of people can be very diverse, and leave families with horrendous questions about what they missed and what's the impact then on them. So I think there is the formal services need to be playing their part in this, but there is definitely a more fundamental community plan and society community-based approach to try and make this something that's okay to talk about and to address the stigma associated with finding the only option open to you is to take your life, and not feeling able to speak up, probably on things that could have been resolved. So I think, just as Tim and Louisa said, it's complex, but the impact on our families, the impact on our society and our communities is huge. It's massive, and then that has a lasting effect.
Yeah, I was struck by the fact that I think it was 10% of people, of families where somebody's committed suicide, that another member of the family goes on to commit suicide, and that's a really concerning statistic. Graham Hardy.
Thanks, Chair. Just the last point for myself. I think a lot of men are kind of with the stigma. If you start involving yourself in the mental health services, then you get stigmatized, you worry you might lose your job, all these kind of things. And I think a lot of men hold back, and again, it's a sign of weakness, some people might judge it as a sign of weakness. And I definitely feel the pandemic's kind of changed all that a bit, which has been a positive thing. And I think it's very important that on a kind of like GPs kind of training in this kind of thing and how to deal with these kind of situations, because the first port of call for many people is their GP. So if the GP's got the right attitude, then it makes things 100% better. So that's just my last point. Thank you.
Okay, just before I ask Tim to draw this to a conclusion, just ask Tim, has there been much research, local research, done here? I noticed there's quite a number of references to national research and national data, but I wondered if there was because of the clearly acute situation in Highland itself in terms of mental health and suicide, that do we need to think about partnering with the local UHI to have some build up of intelligence on which we can then base our policies?
I think there will be scope for more work. One of the, I suppose, challenges with doing the report is that we have commissioned some other work which is not finished yet, but I didn't want to delay the report coming out just to wait and do something else this year just to wait for that. So I think there will be scope to do more, but I think probably what it needs to be done in tandem with putting some of the other measures that we've talked about in, trying to do sort of action research, because there are lots of things that we do know, and we need to act on what we know, and act on the evidence. I think it's disappointing that some of the things, even from a Scotland-England point of view, have not been. Some of the surveys have been stopped in Scotland. That has even carried on within England. That's mentioned within the report. But we need to implement what works, and collect more information in a sort of action-focused way, but so that we can act on it quickly. But I think there's certainly also scope for further work with academic colleagues, just to get to the bottom of why the picture is bleaker within the Highland Council area.
Thanks, Tim. Are we content then to note the Director of Public Health annual report? Yes, okay. And we move on then to the Alcohol and Drug Partnership annual report. And again, Tim.
Thank you, Boyd. We have within the NHS Highland area 2 alcohol and drug partnerships, which reflect the 2 council areas, and they produce an annual report in a particular format which goes to Scottish Government. They have their own different local reporting arrangements, but it's important that the board is aware of the work of the ADPs. The reports, I'm afraid, are not in an overly reader-friendly format, and it takes a little bit of a determination to get through to the bits that are it's all interesting, but the most interesting bits of the report. So I do apologise about that, but that's the format that they come. So really, the reports are here to make board members fully aware of the work of the ADP. If there are specific questions on the individual any individual issues within either ADP, I hope that we have the appropriate people who are here. So Debbie Stewart's definitely here for the Highland ADP. I'm hoping Craig McNally is on the list for the. Oh yeah, Craig has his hand up for the Argyll and Bute ADP. So I think they're far better. If there are specific questions on their work, to answer than I could answer. But the one thing before opening it for questions is also to say that the agenda is, again, a bit like suicide, high profile and really important. Scotland as a whole has got a really, as everyone will know, a really big issue with drug and alcohol related deaths. Huge compared to the whole of the rest of Europe. The government is looking to prioritise that. There are lots of issues that around substance use and alcohol use, which need a lot of attention, and we've got really good examples of individual pieces of work and the approaches of both ADPs in tackling the challenges, but it's a huge issue, and there's an awful long way to go. But I think, again, one of the things that we have to do is make sure that the issues are visible, and so that's why it's important to bring the reports, even in a slightly difficult readable format, to the board today. So I'd be delighted to take any questions, but I'm likely to divert them to the experts.
Okay, thank you, Tim. Colleagues, questions? Anne.
Thanks, Tim, and thanks to everybody involved in the work that is described in the reports. There's obviously a huge volume and variety of initiatives going into our drug and alcohol services. I had a general question from the SBAR for both areas, and that was about progress towards the implementation of the new medication assisted standards, and just a very specific technical clarification in relation to the Highland Council area report. I just wanted to check whether the figures in the finance section on page 17 of the report include the expenditure on the NHS Highland drug and alcohol recovery service, if you like, on the specific health services, or if these figures are around the wider initiatives that we fund across all our partners. Thank you.
Can I ask Debbie to come in first to answer the Highland questions, and then Craig about the MAT standards for Argyll and Bute?
With the MAT standards in North Highland, and we've got an implementation group that's made up from drug and alcohol recovery services, primary care representatives, a whole host of folk. We've also got a representative from a national implementation support team, and where we're at thus far is we've done a mapping exercise, all local drug and alcohol recovery services. The team leads have been asked to map their activity in relation to the 10 standards set out as the MAT standards, and it's quite a mixed picture across Highland. We've also put a funding application into Scottish Government for additional monies to support rollout within North Highland, and more recently we've been doing a bit of networking, knowledge exchange with counterparts in other board areas. For example, the first MAT standard, the government want same-day prescribing, i.e. if someone with, for example, a heroin problem turns up at a service looking for support, the goal is that where clinically appropriate, that person will be provided with a substitute prescription on the same day. That already happens to an extent in Inverness and surrounding areas, but you can imagine in some of the more rural parts, it's very challenging. So the meeting that we had with colleagues from other board areas, they've shared their experience of more of a rotating approach, where staff are based in different areas across the week, which isn't quite the same as same-day prescribing, but it does improve access. We've also met with other areas to look at shared care with primary care. Again, we've got quite a low number of GP practices that are signed up to the enhanced service for problem drug use in Highland. And for example, meeting with colleagues in Midlothian, the way that they've tried to encourage greater sign up from practices is there's nurses from the local drug and alcohol recovery service actually attached to a number of practices, and that seems to have provided a bit of assurance to GPs, and they're a bit more willing to sign up to that service. We've also got a meeting coming up shortly with addiction psychiatrists from a number of board areas with their counterparts in NHS Highland. So it's very much a sort of learning process at the moment, but we're quite excited about the introduction of Buvidal. It's a drug that can substitute for heroin. It can take the place of methadone, and it's got a very low overdose potential. And I suppose the task at hand is to try and get as many people as possible to kind of move over from drugs like methadone that do have a high overdose potential onto Buvidal. And reports from the likes of Osprey House are very positive that clients like it. And there's a number of people that have switched, if you like, and they're promoting it with other people that are coming into service. In relation to your question, yes, the finance section at the end of the North Highland report, that includes the resource spent on the drug and alcohol recovery service. We hope at some point in the future we might get to a stage where we can include the amount of resource, for example, that the council spend, that the police spend, that other partners spend, but we're not quite there as yet. Thanks.
Thanks, Debbie. Can I ask Craig just to come in with anything additional from Argyll and Bute?
Yes, thanks very much, Tim, and thanks for the question, Anne. Yeah, and a lot of the same work ongoing in Argyll and Bute, as you can imagine. We also have a funding application in with MIST, and we're hoping to hear more about that later this week. We've got a meeting with MIST. That's the team that are implementing a lot of the work within the Scottish Government. The one particular thing that I would add to that we're doing in quite successfully in Argyll and Bute is advocacy work, and we have implemented an advocacy programme delivered by the Lomond Argyll Advocacy Service. But they've worked in partnership with other local services and with some national services around the training of peer advocates. That's people with lived and living experience and family members, in order that they can undertake advocacy work within our communities. So we currently have 4 people working within Argyll and Bute area, but we're looking to expand that in the future, in the coming year. Equally, we're at the point that we're looking to develop further partnership, and the same-day prescribing is high on our work on our agenda at the moment.
Thank you, Craig.
Any further questions for Tim and his colleagues? Pam.
I'm probably going to ask a question that Craig and Debbie will say that's been around for ages, but I was just looking at the bit in terms of comorbidity with mental health services, and the kind of, have we any sense of the proportion of people that are involved with both services? And I guess if we don't have protocols to work across, how much room for improvement is there? Because certainly in my career, it's been an ongoing challenge where we start from a service-centred approach as opposed to a person-centred approach, and really dealing with the individual holistically, and no wrong doors was supposed to address that. So I just wondered where you would sense we were at and what the potential is there.
Will I take that first, Craig?
Yeah, I was just going to say you go first.
I think there's a lot of good practice out there. It's not necessarily written down in terms of protocols. That's definitely a big area of improvement for us. I think we've got a way to go. We are still, in some areas, in this sort of chicken and egg situation where you have to have your drug and alcohol problem under control before you can access mental health services, whereas the ADP would argue, well, the issues are likely to be interrelated within the individual, so we have to be able to, or be better skilled at providing integrated responses to people. I think we're doing a fair amount of work in relation to training to upskill frontline staff. In North Highland, people now have easier access to more specialist support for mental health. But we have this kind of situation that doesn't quite fit in the way that we would want. And I think there's a lot of work been done over the past few years to create much more of an open access approach to drug and alcohol services, whereas at the same time, mental health services are perhaps how can I say it, becoming more restricted in terms of access. So you have a kind of imbalance, if you like, that I think is a real challenge. And certainly, I hope it's okay to say, but drug and alcohol nurses on the ground, albeit many are also mental health trained, I feel they would tell you that they perhaps carry some of the work that they would rather do in partnership with their mental health colleagues. But protocols, I think, is definitely a priority and something that we really have to have in place.
The one thing that I would come in and add to that is around structures and how we establish our structures locally. I know that in Argyll and Bute, the addiction and mental health work comes under the same umbrella and are managed through the lead nurse that has got responsibility for both the community mental health and for the community addictions work. That's an important step forward. That's only happened in the last few years, and we're still, obviously, it's been a difficult time to progress any change in the last couple of years, but we're still in that process where we are making progress towards more integrated teams and towards better. I'm reluctant to use the term partnership because that implies that they're coming from different parts of different organisations. They are one and the same, and it's the challenges of breaking with the kind of historic barriers and moving into a new landscape where, as you rightly said, Pam, that every door is the right door. That everybody can access the appropriate care and support by speaking to one person, and that goes for a whole range of issues, not just individuals with addiction and mental health. The one thing that I know is happening in Argyll and Bute, and I believe is happening in Highland as well, is looking at housing in conjunction with addiction and mental health. Very often there is significant issues regarding people's housing coming in conjunction in parallel with their addiction and mental health issues. So it is trying to look at the bigger picture beyond the range that the challenges that are most obvious, and addiction and mental health partnership is one of the most obvious challenges, and we've still got some way to go, but we are making progress.
Thank you.
Thank you both. Fiona.
Thank you, Chair. I couldn't resist joining in, just like Pam can't resist this conversation. Obviously, this is a topic close to my heart with the background that I have, and I think that what I've seen throughout my career in mental health services is a change in the approach and the thinking and the logic, both behind the way that we approach drug and alcohol issues and treatment, but also the way we think about mental health. And I suppose to simplify that for the wider audience, the way we think about trauma and the impact of adverse childhood experiences on people, and the need to meet that psychological need within people that present with a drug and alcohol issue, as well as people that then present with a mental health problem, or concurrent of both. I think as a service, we're still grappling with what that looks like. We still have historic models that don't always glue together that new logic, and we're all working through what that change needs to look like. And for me, a really key part of what we're developing, and we'll continue to develop, is how we wrap mental health care around primary care. The ceiling that I think Debbie and Craig were mentioning was probably about the more specialist mental health services that have had to sometimes take a more selective approach because of the capacity and demand in their service. But where we should be stepping into for people presenting with mental health problems or drug and alcohol issues, or both, is that we get on that front foot we've been talking about in other parts of our meeting today, and I know that we've talked about many times before, in terms of being more proactive, getting on the front foot, preventing and intervening earlier. So for me, how we look at the mental health care, and I mean that in its widest umbrella sense, in primary care, is a really exciting opportunity to do all of these things differently, and to glue the things together that maybe in the past haven't always found it so easy to align themselves, and to work, as Pam says, in that very holistic and person-centred way. So I hope that helped.
Thank you, Fiona. Graham Hardy.
Thanks, Chair. Just to follow up what Craig said about Argyll and Bute and the partnership between addictions and mental health. I do know that the mental health team in Helensburgh do have a couple of addiction CPNs, so just out of interest. Thanks.
The mental health team, and there are addiction CPNs within the Argyll and Bute addiction team, and they will work in partnership with the mental health team. But probably Tim or maybe Pam can correct me in this. My understanding is that the mental health team in Helensburgh is
Greater Glasgow.
Glasgow, yes.
Yeah.
So
Okay.
the service that we have in Argyll and Bute for the addictions is Argyll and Bute. But they all work in partnership. They're based in the same building, different ends of the same corridor. I'm halfway between them. Although that's not been the case for the last 2 years, of course. But yeah, the one thing that I would, just picking up on what Fiona was saying, I think the challenges that you raised, the one word that is significant for both mental health and particularly addictions is stigma, and the challenges that we have around stigma are a major barrier for our services, for our population, and for the whole communities, in terms of ensuring that open door policy is real and true for people, that people feel that they can enter that door without the risk of stigma. The stigma is not necessarily about our services, it's not about how we deliver, it's about whole population and societal stuff. And these are real challenges that even within the ADP we've got some responsibility to help break those wishes.
Thank you, Craig, and thank you, Deborah, and thank you, Tim. We're being invited to take moderate assurance from this report and to note the Alcohol and Drug Partnership Annual Report and Strategy. Are we content to do so? We are. Okay, thank you. We move now back to item 13, the Re-Mobilization Plan. Lorraine is back with us now. She had a very long lunch. No, she actually had another meeting. I'll invite Lorraine to speak to the Re-Mobilization Plan and put it in context for us.
Thank you, Chair, and I've not had any lunch yet, so I will do after this though. Yeah, thanks for allowing me to speak today on it. We obviously submitted our Re-Mobilisation Plan to government on time, and we received minimal feedback from it in terms of how it appeared. It's coming to you today as it needs formally approved by the board so that we can publish it. And as you'll recall, I presented an overview in September that gave I guess a picture of our whole system with the key deliverables and metrics that we're trying to meet at the moment, and we're expected to report them to Scottish Government on the 9th of February and working with the operational teams and all the exec leads on developing that at the moment. I think it's widely acknowledged, as we've seen in IPQR, that the targets that we had noted within the RMP are challenging as a system, and that's replicated across Scotland as part of the group. Looking towards the future, I'm part of the Short Life Working Group that's developing the format for the annual operating plan, so we'll have advance notice of what that might look like and how we might report. But just ask that you note the timescales for the annual operating plan development, and I hope to bring that back as a draft in May. Within the formal development within the July meeting, and that will focus on the next 3 years. As part of that, Catherine, Louise and I, as part of our patients aspect, need to have a recovery plan for all of our activity within outpatients and elective. And I'm keen really to work clinically as well as with management on what that looks like. Along with general practice, really to understand the impact on patients and what that has left us with in terms of our recovery. So I've highlighted the areas that we need decision on today, Chair, and that's just to provide you an overview of RMP. Thank you.
Thanks, Lorraine. Boyd.
Thanks, and I welcome Lorraine's paper and contribution. I think you joined the organisation and picked this up when it was already quite far down the line. I just wanted to make the point, I know that you agree, and you've just mentioned it, that to shape services now as we go forward in 2022, in call it remobilisation, but basically getting back to where we should be with COVID still around and catching up with some of the backlog and running services. That clinical involvement in shaping that is really important, and you've emphasised it in what you've just said, and I'm underlining it so that within the board today there is no doubt that clinical colleagues, and we'll seek patient support and partner support as well, etc. But the clinical sort of leadership and steering and how we do this is really important. So just want to make that point today.
Thank you, Boyd. Any questions for Lorraine? Okay, if not, we're being asked to take assurance that due process has been followed in submitting the plan for Re-Mobilisation Plan 4 in accordance with the commission from the Scottish Government. We're being asked to authorise publication of the plan and to acknowledge that the targets within it are significantly challenged due to the Omicron variant, and that I think that's like. We're also being asked to take assurance that future reporting of milestones will be monitored by the Recovery Board with other committees engaged in matters relevant to the remit, and that quarterly exception progress reports will be required, as indicated by Lorraine, to be submitted to the Scottish Government. And finally, to give assurance that the annual operating plan will be developed on the back of the plan and will be presented to the board in July with an interim update at the board in May. Are we happy to do that? Okay, thank you. Thank you, Lorraine. We move on now to the board risk register, to item 16, and I'll ask Boyd to bring us up to speed with that.
Thanks, Chair. The paper is as supplied, and in the there's an Excel spreadsheet, but the other document, the SBAR in usual format, has a helpful summary table, which is easy to read. In summary, since November, there haven't been any material changes to the level of risk for each of the identified risks in the strategic risk register. So no movement up or down in those. They've remained where they are, and that's since November. The relevant executives responsible have reviewed their risks in the interim, and so this is a revised version, albeit no changes. And we will continue to do this, that this will appear at board meetings, and it will be a matter of revision and consideration in between board meetings, and then presented to board, so that it is a dynamic risk register. And with us now having a head of strategy, I will link more, since this is a strategic risk register, I will make sure that we link more with the head of strategy as well, thinking of this, how we continue to use and shape our risk register and involve execs and the board in that process. You're on mute, Boyd. Thanks. Speaking.
Thanks. Any questions for the other Boyd?
Might even be some catch-up time, you never know.
Clearly people don't have an appetite for risk today.
Thank you.
Any further points? No. In that case, we're being asked to take moderate assurance from the report presented by Boyd around the risk register. Happy to move on to the next item. And we're coming to a series of items now on governance. And the first of these is a code of corporate governance. And Ruth will speak to this paper.
Thank you, Boyd. Yep, so this is the annual review of the Code of Corporate Governance, and the contents that you have before you were considered by the Audit Committee in December. And this year relates primarily to some updates and changes to the terms of reference for the governance committees, and those terms of reference are appended to the report. The changes relate primarily to standardising the notice periods for agenda and report distribution, and for the quorums for governance committees. A couple of our governance committees include volunteer members, and we've had discussions regarding renaming the roles that these individuals play within those particular committees. And on this particular point, I'd just like to make a small correction to the report. Clinical Governance Committee has indeed agreed to rename their volunteer members and calling them independent public members, and this is reflected in the revised terms of reference that's there in front of you. However, Highland Health and Social Care Committee hasn't yet agreed to make a change to the title of their volunteer members, but will be asked to do so within the next meeting. So on that particular point, I'm craving the board's indulgence and asking that at the point when Highland Health and Social Care Committee has in fact made that change, that we can make the change accordingly in the terms of reference for the committee. So I'll be reviewing the governing documents further throughout the year because there will be some more changes to be made, no doubt, going forward. In particular, there are a couple of other documents. We know that the Standards Commission has been looking at the Code of Conduct for board members and has reviewed that last year. They're now going to be using a once for Scotland approach. And the final version of the Code of Conduct will be published in June this year by the Standards Commission. So I will provide an assessment of that to board members and I'll explain what that means, what changes there might be. And I'll bring a report to the board and I'll include that in a suite of governing documents accordingly once it's been published. And similarly, we're anticipating an imminent update to the blueprint for good governance. So again, I'll review that update and bring a report to the board as soon as practicable. So as I said, the changes to the code have been agreed at the Audit Committee, and I'm recommending that the board takes moderate assurance from the report on the basis that there will be ongoing assessments of the various components throughout the year. So it's a constantly changing situation. So the board's invited to approve the revisions to the Code of Corporate Governance as agreed by the Audit Committee and to agree that the terms of reference for the Health and Social Care Committee can reflect the decision taken on the renaming of their volunteer members. Note also that I will provide a further assessment of the updates to the blueprint and the Once for Scotland Code of Conduct for board members whenever they're published. And as soon as we've updated the Code of Corporate Governance, we will refresh the version that's on the website at the moment. Thank you.
Okay, Ruth has set out the recommendations very clearly there for us. Are there any questions? Are we content to ratify the updates subject to a further change with the Highland Health and Social Care Committee, which will be made at this next meeting? Are we happy to ratify? Yes, okay, thank you. And Ruth, you're on again. Improvements to the board framework.
Okay, so this is the report that focuses on progress in implementing the main findings of the internal audit review of our board assurance framework. And I'll briefly highlight some of the areas where there's been progress since the last meeting. We've been rolling out the assurance reporting mechanism through the committees. It's now started to be used in governance committees. And as you'll have noticed, it's been used for all of the reports at today's meeting. And it draws particular attention to the corporate objectives, to NHS Scotland quality ambitions, as well as focusing on the level of assurance that is being delivered to the board. We're improving awareness of assurance throughout the organisation and within the board. And I'm going to be making arrangements with committee chairs and lead executives for us to consider and make arrangements for preparatory meetings ahead of committee agenda distribution dates, so that you'll be able to have a better understanding between you of how this might work. And the intended outcome is that we'll improve our understanding of assurance and we'll have better oversight of the quality of reports, as well as ensuring that they're distributed more timely. We've just reviewed the corporate documents, so that was one of the particular points of improvement within the improvement plan. And turning to self-assessments and committee work plans, given that we're still operating under pared back governance, committee chairs have decided not to rerun the self-assessment exercise at this particular stage in the year. However, we are going to be looking at the outcomes of the last exercise that was done and review any further improvements that need to be made. And we'll give further consideration to when we will rerun the exercise, when we're in a position to do so. And committee work plans will be generated over the next month and fed into your next round of committee meetings, with a view to them being agreed and brought back to the next board meeting. So the report also provides some commentary on risk management and how the development of our strategy will bring together many of the loose ends of this particular improvement plan. And I'm recommending that the board takes moderate assurance from the report on the basis that there has been progress with the improvement plan, and recognising that there are still many other areas of improvement to be attended to. And I think from my own personal perspective as well, good governance isn't achieved through procedures and metrics alone. It's got that intangible quality, relying on all of your abilities and your curiosity as a board. So from that perspective, this is an ongoing endeavour to make improvements in governance. So the report is there for your information.
Are there any questions on anything that Ruth has said or anything in the report? Are we happy then to agree to take moderate assurance from the report and note the progress that is contained within the report? Susan, sorry, you wanted to come in, sorry.
Sorry, thank you, Chair. Just a brief point. I mean, I really appreciate the assurance statements that we've got, but I note that almost everybody is giving us moderate assurance. And if everybody does that, that's kind of less helpful. What I did note was that I think it was Fiona's one on the culture where it was moderate, but she then gave a short statement about what it would take to take that assurance up to substantial, and not to give people more work, but that just another sentence to say what is going to happen to move it up would be particularly helpful. I appreciated it in that particular report. Thank you.
That's a good point, Susan. Gaynor.
Thank you. Just to say yes, I agree with Susan. I'd meant to make that point at the time. I think the proposed level of assurance presented with a paragraph of explanation really reinforces it for me as a board member. So that would be really good if we could have that in each of the reports going forward. Thank you.
Okay, we can take that forward as well. Absolutely, that's no problem. And clearly within committee meetings, it's within your gift to scrutinise and ask. So that's your role too. So.
Bearing that in mind, are we content to take moderate assurance from the assurance report or the board assurance framework, and to note the progress? Yeah, okay. And the third of Ruth's reports is on the membership of committees. Ruth, again.
Yeah, well, on this one, Susan, I'm actually recommending substantial assurance. We've now proposed full committee memberships across the committees. And as you'll see there, the report speaks for itself, actually. The only thing that I believe needs to be done now is that we need to appoint a vice chair for Clinical Governance Committee. So the memberships are there for your approval.
Are we happy to take substantial assurance from this report? Okay, thank you for that. We move on now to the last section on governance and other forms of assurance through the committee reports. And I'm sorry that you haven't had all the reports in written form very early on with the other papers, but we've had most of them, and I'm going to ask people to speak, the chairs of committees, to speak to them. But on the first one, Alistair had to leave the meeting early, but I think he has spoken to Jerry to ask Jerry to speak to the Audit Committee report.
Yes, thank you, Boyd. The minutes are there. The minute is there of our meeting on the 7th of December, and I know a few colleagues have already referred to it in the meeting today, so I'm assured that it has been read. We picked up a few items. We had the first draft of the 22-23 internal audit plan, and I think that's now subsequently doing the tour before it comes back to the audit committee, hopefully in March, for recommendation of approval to the board. I think should highlight that and I think Bert picked up earlier, we had the internal audit on the significant adverse events, and we've asked for a report to come back to the March audit committee on that, and I've got no doubt Boyd is overseeing that. And finally, we're getting to the real tail end of the outstanding audit recommendations, and we're really now just having discussions about how we manage the residual risk, where there's really no further action which is practical for us to take in terms of delivering the points that was raised, which is really encouraging. And the message that's coming out of that as well is actually to be quite careful when we're agreeing the wording of recommendations, so that we're not leaving ourselves totally open-ended to something which is actually virtually impossible to close, and there'll always be a level of residual risk. But happy to take any questions. Thank you, Boyd.
Thank you, Jerry. Any questions for Jerry? Just further to Jerry's report, you may or may not be aware that the Auditor General and our external auditor were called before the Public Audit Committee recently to give evidence on our Section 22 report, and that seemed to be quite a satisfactory meeting from our point of view. There were no major issues highlighted. We haven't had as yet a written report or letter from the committee, but we just hope that we, Pam and I and Dave, are not called before the committee again. Okay, can we move on then to the Staff Governance Committee of the 12th of January? Sarah?
Thanks, Boyd. So this was a slightly shorter meeting, reflecting our pared back governance that we're observing at the moment, and we've also paused our development activity, but we used the time to go through some key areas, many of which have flowed through to our agenda today. So looked at things like the whistleblowing report, the culture programme progress, that you'll be able to see from the minutes, which were just recently circulated, and we really just kept it to those key areas. The one piece of work that we took away from that is obviously as a result of the pressures of the Omicron variant, we have had to make some adjustments to our action plan, just to keep things moving along, but to reflect the updated timeframes. So Fiona and I are going to take that away for our planning for our next meeting, but nothing significant that I need to bring to people's attention at this point.
Any questions? Thank you, Sarah. Any questions for Sarah? Okay, we move on to Anne and the Highland Health and Social Care Committee of the 12th of January.
I don't have anything to add to the minutes. Thanks, Boyd.
Thanks, Anne. Anybody have any questions to raise about the minutes? If not, we move on to Clinical Governance Committee, which met on the 13th of January, and to Gaynor.
Thanks, Chair, and apologies that we didn't have the minutes ready for the meeting today. It was again a shorter meeting due to the pared back governance, but committee members received assurance on infection prevention and control, the evolving clinical governance measures in the Integrated Performance and Quality Report. We also received assurance on the internal audit report on significance adverse events that Jerry mentioned earlier. We also sought assurance on the annual meeting between executive directors at NHS Highland and Health Improvement Scotland. And under the public health item, we received assurance on the vaccine transformation programme. The committee also sought assurance from each of the operational areas, these being the Argyll and Bute Health and Social Care Partnership, Clinical and Care Governance Committee, Highland Health and Social Care Partnership, our acute services, and the Infants, Children and Young People's Clinical Governance Group. And matters discussed included an increase in falls in some of the hospitals, pressures and capacity in mental health services, and the availability of clear masks for staff interacting with children, as well as an update on the progress of setting up the Child Death Review Panel. The one thing that the committee would like to raise to the board's attention specifically would be that we were not going to meet the Scottish Government target for the number of C. difficile infections within the board this year, and I don't know if Heidi might want to come in and say a little bit more about that. But otherwise, happy to take questions. Thank you.
Heidi, do you want to come in just now?
So thank you, Boyd. So this isn't new for the board, and I've been alerting the board for a little while now that I didn't feel that we would probably achieve the Clostridium, sorry, not Clostridium, but the C. difficile target, and also we've spoken about the E. coli position as well. Just to explain to the board that despite the fact that we're not meeting the target, which is to be met by the 31st of March this year, we are within predicted limits, and this means that we have a range that is set for us in terms of our that's influenced by the number of patients that we see and the case mix of those patients, so what's wrong with them and how poorly they are. And it is our aim is always to ensure that we are sitting within that range, and indeed we are. But nonetheless, we are not going to meet the target, I don't think at all, this year in relation to E. coli and C. difficile. We have action plans in place, and I've asked the infection control manager and also the lead infection control doctor to review those plans. We've had conversations with the government in terms of, are they happy with our plans? Is there anything else that we need to add? Is there anything that we're not doing? And they are happy with our plans and haven't asked us to do anything different. So just wanted to alert the board to that. I'll have a final figure though for the March board.
Thank you, Heidi. Are there any questions for Gaynor on clinical governance? Can't see any. Thank you, Gaynor. And next one is the Area Clinical Forum on the 13th of January, draft minutes. Katrina.
Thank you. I don't really have anything to add to the minute. It was a reduced meeting, but it had very strong turnout, which was very good. So the discussions were fairly robust, and we're in the process of hopefully having a vice chair in place to support me at the next meeting. So, but I'm happy to take any questions.
And we continue to encourage non-execs to attend meetings of the Area Clinical Forum, and I think Anne has been coordinating some of that activity in the past. I don't know if Anne, if you want to come in on that.
That is the case, but I think that at the moment, Ruth and Nathan might be working on that behind the scenes on getting a refreshed rota for the coming year. So I can't claim to have had that much involvement this time round, Boyd.
Okay, thanks. And are there any questions for Katrina on her debut?
Yes,
Pam.
not so much a question, but probably just a comment in relation to the culture piece that was fed back in terms of discussion around the culture programme and some of the reporting and the clarity of what was in the public domain and what people knew. So Fiona Hogg did do a follow-up, which I hope was helpful, Katrina, of everything that's been in the public domain through our board, from both the healing process and from the previous root cause analysis that we did with a certain group of people. So I think it's just important to note that, because there clearly was a bit of anxiety around what wasn't being shared and what was being shared, and I think hopefully we've demonstrated the open and transparent way in which our culture programme is being communicated publicly.
I did speak to Fiona this week and got some sort of ideas as to how we'll move that forward as well, to make sure that those things are available transparently every time we meet. So yes, that should keep the conversation going in the right direction with that as well. Thanks, Pam.
Thank you, Katrina. And the final report from Sarah on the IJB.
Thanks, Boyd. So this is where our cycles of the IJB and the board are a little bit back to front. So the meeting of the minutes that you see in front of you was the one that actually took place just prior to our last board meeting. It's a little bit out of date now. Nothing particular to draw your attention to, other than just to highlight that we took a positive step in appointing 2 new carers rep and 1 public rep to the IJB, which had been needed for a while. So that's a really important step for us in strengthening the membership around the board. And the next meeting of the IJB is tomorrow, and that will be their first official meeting. So I will report back next time. Thank you.
Thanks, Sarah. Any questions for Sarah? If not, we're being asked to confirm adequate assurance has been provided from these governance committee meetings, and to note the minutes and the agreed actions from the Area Clinical Forum and the Argyll and Bute IJB. Are we content to do so? Is there any other competent business? Just wanted to flag up one issue in regard to the development days, which usually precede board meetings on a Monday. We had to change it in January because of a clash with the national meetings on the Monday, and we may have to do that for other meetings later in the year. But we'll meet. Pam, Ruth and Anne and I will have a discussion about the dates and come back to you with a revised schedule, proposed schedule, if that's acceptable. Okay. And the date of the next meeting of the board will be the 29th of March. Well, we've reached the end of the day, and thank you very much indeed for your contributions and for the quality of these discussions that we've had today, and hope you enjoy the rest of the month. And remember, again, it's Burns Night tonight.
Thank you.
Bye for now.
Thanks everybody. Bye. Bye.
Thank you.